Hey everybody, it's Ed Dellard here from ABA, and I wanted to take a few minutes and an opportunity. I got introduced to Dr. Spencer when I was at the Western Regional Burn Conference just a couple weeks ago in New Mexico, and I was so inspired by her presentation that I asked if she would be willing to come back and kind of share some of her points that I thought were super important for the burn community. For those of you who don't know Dr. Spencer, she is the chief burn psychologist at the Arizona Burn Center and Valleywise Medical Center in Phoenix. She's a licensed clinical psychologist. She has a whole litany of certifications that are out there. Just to highlight a few of those things, she's got her doctorate degree in clinical psychology. She's got a Master of Science in Clinical Psychopharmacology. She did a postmaster certificate in trauma counseling. She's also got a certificate in cognitive behavioral therapy. She does a little bit of assistant professor work, for University School of Medicine. She's also provided clinical supervision for CBT, some of the psychiatry residents. She's done a lot of community work. She's done a lot of psychological evaluations for children, skilled nursing rehab centers, fire EMS departments, prisons, older adult protective services. I could keep going on here. I think you'll get the picture that Dr. Spencer is a wealth of knowledge. And so I'm just honored that she is taking a few minutes to kind of talk and share some of her points that she shared at Western here. So Dr. Spencer, thank you. Is it okay if I call you Michelle?
Yes, please.
Okay, all right. So I think the first thing I really wanted to highlight for ABA members who might not be familiar with some of the terms that you were talking about in your presentation. And I know it's been in the literature a little bit about secondary traumatic stress, but why, can you kind of help us with why is that so especially relevant in burn care?
This secondary traumatic stress really is the distress that we can feel once we hear a person's trauma. And if that is continually repeated to us and we are navigating the care that that person needs, it's sometimes called vicarious trauma or vicarious stress. I mean, those things are kind of used interchangeably, even though they're not exactly the same thing. And so, I was just in rounds this morning, and every person that we go to, we get their name, their age, and how they got injured, and then we jump into what's happened. So every single day, twice a day, we're reminded of what happens with this patient. And we're also reminded of what's happening with this patient as we're delivering care during the day. So again, it's a cumulative load as well. And that's what makes it so difficult for specifically in the burn world.
You talked in more detail about this and about some of the stories that I think burn providers, and have, right? And they have a number of stories. And they're complex stories, in regards to the exposure that they have been dealing with in the acute phase, right? And they go into that mode of, doing what they need to do to take care of patients. So my thing is here is what makes burn care so uniquely vulnerable to this kind of stress, and what are some of your recommendations around that?
So one, can I recognize the elephant in the room? I'm hearing a squeaky toy behind you, or am I just making that up?
It's all right. It's just my dog, and I can't deal with it, and it's okay. And I want to mute myself. And for ABA members, welcome to Ed's Entertainment.
Yes, we love dogs here. I'm hard pressed to find a burn provider who doesn't love dogs. So I'll tell you one of the things about burns, and if you are in this practice space, this, that burns are a family injury. They're not just the patient. And so on top of managing what's going on with our patients, we're also managing what's going on with their families as well. And how do we get all of that stuff together? And the fact that burns are a lifelong injury, and I always make this analogy, is you break your arm, you go to your orthopedist or you go to the ED, they set your arm, they put a cast on. 6 weeks later, 14 weeks later, you can tell I've never broken an arm. however many that is, they x-ray you again, you're good to go. They cut the cast off and off you go, and never to be seen again, or never needing to be seen again. Is typically quite longer than any other service or any other discipline. Maybe trauma has people that they keep as long, but one of the things that we manage with is like the unfortunate part of our work is when we have people for this long, long stay, we regularly have to inflict pain on them in service of doing the treatment, multiple surgeries, daily dressing changes, regular debridements. And so that is part of why we struggle so much.
Yeah, and I agree with that, and I think that's so important. You talked in your presentation about emotional suppression by the professional teams, and you provided some tactics maybe that the team might, want to consider in all of that. And I think it's different depending on the role and responsibility of the burn team, from surgeons and what they're doing versus the nurses versus the therapists all down the road in regards to what they're having different roles, responsibilities in the care of that patient.
Right.
And every one of them got their stories in and around that same patient. And you talked about that emotional suppression and how to get that out. What's your thoughts about that, especially depending on the role responsibility on the team?
Right. So the talk that I gave talked about the intersection of stoicism and psychological well-being. And stoicism is a philosophical discipline that's been around just seems forever. And it talks about we don't have control over the things that we're exposed to that we see. What we do have control over is our thought processes and the way that we respond to these emergencies. And, or I shouldn't say just emergencies, but the way that we respond to what goes on around us. And I think that that's a really important thing. We all know that we have to present ourselves in a certain way. You don't want your burn surgeon in tears at your bedside because that gives you a very distinct message that things are out of control. So I'm not a big believer in suppressing emotions. And so the idea of having enough insight and tools to manage the way that you respond in the moment and then later on are able to reflect so that you can maintain a healthy interaction. And I think our patients deserve for us to be very authentic with them. So I don't want to say that we're encouraging emotional suppression. We're encouraging a professional comportment that includes maybe a poker face at times and other times being wildly happy or wildly sad for your patients. And I think our patients know that that level of sincerity is genuine. And that really goes a long way to join with your patients and to help them through their healing process.
I'm going to say it this way, and I want to kind of get your reaction to this. We're humans, and we all have to deal with certain things in our own way, even care providers. And I think sometimes that's important for patients to understand that or even see that. And I think we try to suppress that as you were talking about. I really thought too the tactic you talked about debriefing, after a major event that's happened on a unit, for the team to kind of come together. I don't know how often that happens around the burn units in the country. My guess is it's very sporadic, is my guess.
Probably, yeah. Yeah. And so part of where I'm going with this, if you're fully ensconced in the critical incident stress management world, there's a difference between diffusing and debriefing. And debriefing is a more organized, stepwise, and there's a whole variety of types of debriefings. But diffusings are the um, more immediate, kind of bringing everybody together and processing what just happened. Because sometimes there's a bit of derealization that goes on that you just can't believe what you just saw or what you just had to participate in. And, as I'm saying this, a number of events that have happened in the burn center, I've only been here 4 years. And I'm saying only because we have people here at the Arizona Burn Center who have been here for 40 years, have been here for 30 years. And so I'm a new kid here. It doesn't matter that I bring 20 plus years of psychology experience. I'm a baby here. And so I'm saying just here for 4 years. And so those things kind of leap out at you. And, to be able to kind of diffuse, kind of get that your psychological process of engaging with the cognitive and emotional aspect, that's what the diffusing is for.
Thank you for that.
Yeah.
I want to try to personalize this in recent news events that are happening, specifically
Yeah.
kind of in your area of the country out west with this wildfires. And ABA just put out a press release right before the 4th of July, and trying to emphasize prevention, safety. But it was another reminder, I think, of the sacrifices that firefighters, EMS, first responders do. There were 3 deaths, in Colorado with firefighters that were out there. But it all kind of comes back to us and our community related to disaster-related trauma. And that does affect patients, it affects families, it affects the responders in the communities, both general public as well as the caregivers again. What should burn centers be thinking about in how to prepare their teams emotionally as well as clinically when we hear those stories and we know and correlate those to things that we've experienced in the burn units overall, especially when it's a firefighter coming in for care.
Right. So, part of this is, when you hear about these things, and yeah, these are wildland firefighters. My background of being in the fire department is from the Philadelphia Fire Department, and that's structural firefighting. I was on the paramedic side. My husband's a retired battalion chief. He spent 32 years fighting fires. And so whenever I see something like this is very personal for me. And, one of the things that I do recognize is that, when you have public safety individuals, they're at risk, they're at heightened risk every day for being seriously harmed or injured. And so part of what we do here, we have this lovely woman, Suzanne Buchanan, who does our outreach and our teaching. She does feedback for our departments around the state. Anybody who sends a patient to us can get feedback about how the patient is doing or, what happened. Did they get to us or did they get transferred elsewhere? Things like that. And so I think having that information is really helpful. I think that helps people kind of close the mental loop of what has, that you put your life on the line to save a person, and then you don't know what happens to them after you leave them at the hospital or after they're airlifted away, something like that. And after a career like my husband's career, which was 30 plus years, that's a lot of open loops if you can't close those. And so, that's a protective sort of thing, is to have your department and to have your units be able to fill in those blanks for you, because then you're not constantly worrying. Because one of the things that happens if you have all those open loops is that you start to wonder if what you're doing is worth it.
Yeah.
And that makes us particularly vulnerable to this compassion fatigue, this vicarious trauma.
I'm going to get to my last question here. This is I could continue on for all morning here with you on this topic. We ABA just did a workforce study recently in 2020. I talked a little bit about this at the Western Burn. We're still analyzing the data, but there was one key point in that really why your presentation kind of reached out to me, which was there's a fair number of respondents on our survey that have been in the burn community for quite a long time. I mean, these are not somebody that's just been around the block, once. I mean, they've been around the block several times.
Right.
But they did talk about the stress. They did talk about burnout. They talked about the call schedules and the aspects of some of the experiences that they have, and that weighs on them considerably. And that
Right.
came out in the survey loud and clear. And I think it was kind of way to reach out to ABA is like, we need some resources, to kind of help us to, how do we deal with this? And that's the reason why your presentation I thought was so relevant, just based on that one data point. And this is, more so from the nurses, I think, and the therapists. Surgeons, not so much, but they may not have wanted to, freely talk about that openly or respond on the survey accordingly. But I don't know. But I have to assume when you see something like that data-wise, if that's a strong indicator, probably across the team. Okay, so I'm saying all of that is that if you could impart on ABA membership one message, whether it's nurses or physicians or therapists or advanced practice providers or whoever that may be on the team, about what would it be that you think is most important from the kind of the take-home message from our brief discussion this morning? What are things that they may want to do tomorrow that might be small but might have mighty impact?
Things jump out at me. And, having worked in EMS since 1974, we're talking over 50 years, I am working in a lot of different systems. One of the things that when you're working in this environment, when you're working in a hospital setting, in a public safety setting, is the feeling of being helpless. We can't stand that. And so when your charge nurse says to you, you got 4 critical patients today, and that's just ridiculous, right? Because if you ask anybody in public safety, span of control is 1 to 4. When you're talking critical, it's 1 to 2 or less, right? So having that weight, that awesome responsibility on your shoulders for people's health, safety, and well-being, which we all do in the burn community, right? Sometimes overly so. That is a huge amount of water to carry. And so one of the things that I encourage people to do, this would be my very big take-home message, is practice with gratitude, because we are front line in the burn centers. We are front line pre-hospital, and we get those awesome responsibilities. And I mean awesome in not such a good way, but we have the awesome privilege of being good at what we do and being able to intercede and put a little order on the chaos. And for me, that is the thing that I have to do every day, is recognize that my worst day on this side of the bed or this side of the stretcher is better than any burn survivor's best day on that side. And I am grateful that I get onion rings for lunch and nobody's looking over my shoulder when I'm having that, or that I get to go home and watch Netflix, or I get to go home and listen to a webinar. Yeah, I'm a nerd. Or something like that. Do you know what I mean? Or I get to go home to my lovely husband, and my sister gets to go home to her grandchildren. Those things are huge. And so that's the thing that I think is, if you have one thing that you can do at the end of a really lousy day, before you put that key fob in. I was going to say put the key in the ignition, but I guess that tells you how old I am. Before you can do that, you could just think about 1 or 3 good things that happened to you. And waking up, that's enough, but that's not good enough for us, right? It's like, you know what? I got out of this shift with my panties intact. A little raggedy, but I got out. Being able to embrace that, then let you leave your work stuff at work and you transition to home.
Michelle, I think that's an important message, and I hope people will take action on your suggestion with that. From my perspective, I'm inspired by people like you and others that I get to communicate with in the burn community. It really is awe-inspiring to see the work that you all are doing on a day-to-day basis. And I think sometimes we take that for granted. And I think we need to be reminded about the important work that everybody is doing, no matter what your role and responsibility is in that burn unit. And so I just am grateful from my perspective of just having the privilege to be a part of this community and learn from you all. And I think that's an ongoing process. It never ends. So I'm going to thank you, Dr. Spencer, for spending time. I know you heard and I know everybody else heard my dog, so I got to show my 3.5-month puppy here. The dog lovers that are out there. But this is Rizzo. He is my colleague here, and he's still learning. accordingly. But obviously, I'm a dog lover. So
Sure.
I know everybody heard Rizzo, but this was the squeaky noise that everybody heard, and thank you for tolerating that. Dr. Spencer, thank you so much for giving me a little bit of your time today and your expertise. I appreciate it, and I know ABA membership appreciates it. Thank you.
Thank